Good afternoon. My name is Dr. Bambi Gaddist. I am the Executive Director of the South Carolina HIV/AIDS Council. We're located in Columbia, South Carolina. Our governor says it's a great day to be in South Carolina, although we're not accepting ACA funding. And we have many gaps, many of which we're speaking about today. So in case you're in the wrong session, this is Reducing Infectious Disease Disparities in Minorities. And I want to thank each one of you for maintaining your presence, for two authorities that will be speaking around the hepatitis concerns that we are now facing. Once a disease that we rarely heard about, but more recently, in the past decade, it has continued to grow to a place where we are deeply concerned. We know that between 2008 and 2012, the CDC monitored over 35 outbreaks of hepatitis B and C. And of those, about 94% were in outpatient facilities. Some of them were oncology centers. Some of them were in other off-site clinical settings that were outside of the hospital. And I'm certain that many of you have already heard about the case in Oklahoma, where over 7,000 people have been exposed. And to date, approximately 55 have tested positive for HCV, much fewer amount for HBV, but they have no idea as they still continue to call folks in to see if they've tested positive. So outside of the clinical setting, we also have a behavioral epidemic that is leading to infection, whether it's IV drug use, etc. For many of the people that become infected, it will be a sudden onset where they think they have the flu, but it never goes away. And for others, it will be a long time, it'll be a gradual onset where they won't know exactly what's going on, but they know something's incorrect. And unfortunately, for so many individuals who will face this in the next days to come, they'll present themselves to a physician, and that physician will debate whether they'll give them treatment or not, and whether they can afford the expensive treatment that it will require. So with that as a backdrop, with other issues that are related to it, I'd like to introduce to you one of our federal authorities. Dr. Monina Klevens is an epidemiologic surveillance officer for the Centers for Disease Control and Prevention. She currently works on measuring burden and characterizing the epidemiology of viral hepatitis in the United States. She has co-authored and authored over 50 articles and has given presentations to varied audiences throughout abroad. And as a fellow of the Infectious Disease Society of America and a member of the Society for Healthcare Epidemiology of America, we would like to welcome Dr. Klevens. Let me say one more thing. We have Dr. Charles Howell, who is detained in another room. What I'd like to do for the sake of time is to go ahead and introduce Dr. Howell to you. And so when this man appears on the stage, you'll know exactly who he is. I also want to note that he is my homeboy. We attended Tuskegee together. And so we have a long history of being in a climate that has been under some review for many decades. Dr. Howell is a professor of medicine in the Department of Medicine, Division of Gastroenterology, and Director of Hepatology Research at the University of Maryland School of Medicine. Dr. Howell has a long-standing interest in racial disparities and chronic hepatitis C treatment and was an investigator in the NIDDK Vera Hep C study. Dr. Howell's clinical interests include management of chronic liver diseases, particularly hepatitis B and C. And so without further time, Dr. Klevens.
Thank you very much. It's such an honor for me to be here. Thank you. Thank you for inviting me. Thank you for including hepatitis C on your very busy agenda. Let me see how to move these forward. Next. Okay. So what I'd like to do is, I think my job is going to be to bring you closer to understanding. In this case, we're not so concerned about preventing primary infections, but rather we have a lot of people that are already infected. With those people, we need to actually do secondary prevention. So we'll talk a little bit about new infections, but mostly about chronic infections. And I'll do that by dividing my talk in these three parts, and including a little bit about sources of data so that you can move your own research forward and use data at the local level. So one of the reasons that this is new is that, in fact, hepatitis C is a relatively new virus. The test was developed in 1990. Before, we used to call it non-A, non-B, and until just very recently, we stopped receiving reports of non-A, non-B. So it's a single-stranded RNA virus, which means that there's less quality control actually as it replicates, and that causes different things. One of those things is that a person who has been infected and then resolves infection either spontaneously or with treatment can become reinfected. And it also makes difficult developing a vaccine. The other issue I wanted to mention here about the actual virus is that there's a lot of genetic diversity, and that reflects in the treatment choices. And there are 6 genotypes. Subtypes are also important. And then there's some new developments in host genetic characterizations that also impact treatment. There are 5 hepatitis viruses that affect humans and cause disease. We're only going to, I don't know if I have a pointer here. We're only going to, yes, here it is. We're only going to be talking about C, but you can see that C is similar somewhat to B in how they are transmitted. But the difference is that there is not a vaccine for C, whereas we do have vaccines for B and A. C is also more complicated compared, for example, to A, because A does not produce chronic disease, whereas B and C do. This is to show you a little bit about mode of transmission. For a long time, I think there's been a myth about sexual transmission, and you can see that, in fact, there are studies of monogamous heterosexual couples that show pretty much no transmission heterosexually. But we've seen some problems in men who have sex with men and some other types of sexual transmission, but you can see here that it's not as common as injecting drug use. In addition to that, before screening tests were available, there were a lot of cases that became infected from transfusions, from organ donations, and as Dr. Bambi just mentioned, there's still some healthcare transmission, although that is also very rare. So the way we look at this from a surveillance perspective is in 2 very different disease events. And this is something that is not done in other countries, in few other countries, let's say, because a lot of other countries just decide we'll monitor antibody at best, or jaundice if they don't have laboratory infrastructure. But distinguishing, as I'll show you in the next slide, acute from chronic is very difficult from a surveillance perspective. So actually, for the case definition for acute disease, we require symptoms, which you'll see is a minority of cases, and laboratory criteria, so they need to have an antibody. There's no IgM that allows us to identify acute disease. The way we find these is from health departments, the National Notifiable Diseases Surveillance System, NNDSS. From labs, they report biomarkers that are positive to health departments. Health departments maintain databases, they deduplicate and allow us to understand which cases are new. Then they go out and investigate them so that they can determine if symptoms are present or not, so we can classify as acute. But the majority of cases are actually either past or present or have present infection. And we're not going to talk about the algorithm for identifying those in public health, because that algorithm, a new algorithm, is going to be presented in May in an MMWR. And the source for these data is NHANES, and I'm actually going to tell you a little bit about NHANES. But this is to explain why it's harder and more complicated than hepatitis A. So when a person becomes infected with hepatitis C virus, most of the cases do not present jaundice. So 80% of the cases here, the numbers exactly, some of this information is based on blood transfusions, so the cohort information might not be as updated, but this is what we know about the natural history. In fact, fewer become jaundiced. And these are, as I mentioned, symptoms are required to identify for surveillance to count an acute infection. Many of these, so some of them are resolved, but many of these become chronic infections. And the progression after chronic infection from infected but asymptomatic to consequences of infection, such as cirrhosis, hepatocellular carcinoma, and eventual death, depend on many other factors, whether there's treatment, alcohol use, other factors. So remember what I told you about acute disease. So there are fewer of these, but we continue to monitor these through the health departments. And what you can see is here some of the data by race ethnicity, that there was a sharp decline, which is when we turned to start dealing with the issue of the chronic cases, because everybody thought we've already taken care of new infections, so we'll deal with all the burden of chronic. But so you can see there were declines, but very recently there have been some increases. And I don't know if you've seen some MMWRs in that area where young people have been increasing the frequency of injecting drug use. And wherever there is a prevalent case that might be in that mix, then there's transmission of hepatitis C. So there was an example in New York State. There was a recent one in Michigan. And we've been investigating these further. I wanted to tell you a little bit about NHANES, and I'm glad because you've seen a lot of data from NHANES. It is actually a sample. It collects information from a nationally representative sample of the US civilian, non-institutionalized population. There are over 5,000, but close to that number of participants per year. They undergo a physical exam, there's an interview component, and there's a collection of specimens. For hepatitis C, those specimens are actually analyzed at CDC. It's important that it excludes institutionalized persons because they might be at higher risk of hepatitis C, so the CDC estimates might underestimate the prevalence of hepatitis C from NHANES. One thing that this does not do, because it's a national sample, is allow state-specific, let alone county or zip code-specific presentation of prevalence information. All right, so what I'm going to be showing you from NHANES consists of sort of these three numbers. One is the prevalence, and then below that you'll see that I'm showing two numbers which represent the confidence interval. Because this is a sample, that means that if you repeated this 100 times, 95% of those times, the answer would actually, or what you think is the truth, would fall in between those numbers. So you will be able to understand several of my slides. So you can see actually this is the prevalence of antibody. An antibody could be either past infection or current infection. So it's experience of infection with hepatitis C. From NHANES, when you actually apply the weights, the numbers that you'll see are that there are in the US, and this is old, there's a new one of these papers right now under review that'll bring us up to 2010. But so this is what we have that's available right now. That there are an estimated 4.1 million US non-institutionalized people with history or antibody that are antibody positive for hepatitis C. 3.2 are actually RNA positive, so that is that they have current infection. And you can see that prevalence is much higher among non-Hispanic blacks. And this is just sort of to show you the sample size of those. These are the odds of having a positive antibody. And what this is saying is that there is a greater likelihood, adjusting for risk, that Hispanics were 2.6 times more likely to have antibody positive results compared to whites. Whites are the reference group here. So they have an odds of 1. And non-Hispanic blacks had almost 2 times the likelihood of being antibody positive. This I wanted to show you because it feeds into the new screening recommendations. And that is that the age of the current prevalent cases varies. First of all, prevalence is greater among males than females, and so this breaks down males by race ethnicity. And what you'll see here is that the prevalence is greatest among 40 to 49-year-olds among whites. Similarly, 40 to 49-year-olds among non-Hispanic blacks. But some of the other age groups are a little skewed among Mexican-American participants, where the prevalence is higher among 50 to 59-year-olds. This uses NHANES data to forecast, in addition to other sources of data that assume the frequency of morbidity and mortality in hepatitis C studies, what we can expect as far as morbidity and mortality over the next years. And it shows that the peak is between 2030 and I think it was 2035 would be the time when we would expect the greatest number if people continue with the treatments as currently available. But since we know that there are very good changes in therapies, and we'll talk about that, and Dr. Howell will expand on that. But the consequences already are visible now, so we don't have to wait until 2030 for that. This is a study that includes as a cause of death any mention of hepatitis C as a contributing cause, not only underlying, and the same is true for HIV and HBV. And it showed that in the US, around 2006, there was a crossover in the frequency of deaths where hepatitis C, shown in yellow here, crossed over the frequency of HIV. Hepatitis C crossed over HIV, where when you look at a trend analysis, there was actually a decline in HIV of pretty much the same amount per year as the increase in hepatitis C. But when you break those deaths down by race ethnicity, you can see a disproportionate burden, again, among minority populations, where the frequency of deaths, this one compares to people who are HCV negative. So the likelihood, the crude odds of death among Black non-Hispanics was almost 2 times higher if they were HCV positive than if they were HCV negative, comparing to other non-Hispanic blacks. And for Hispanics, that was much higher, so that their likelihood, their crude odd of likelihood of death was 3.4 times greater if they were HCV positive than if they were HCV negative. And this is just so that you can start thinking about costs, where hepatitis C remains the greatest. This red group here is about 37%, the single cause of transplants. And in the literature, it's estimated that one transplant can cost about $126,000 in healthcare costs. And so what's going on here? This actually uses a follow-up survey of hepatitis C, people that were in NHANES and notified with a letter that they were hepatitis C positive, because as I mentioned, at the time they collect the specimen, but then those go to the lab at CDC. Among the people that are identified as positive, they send them back a result. So then after the result, they wait 3 months and they contact them to do an interview. So the results here are shown how many people during that interview responded that they had ever heard of hepatitis C. And you can see that the frequency among non-Hispanic blacks is lower, never heard of hepatitis C. The other problem is that they're unaware of their infection, where non-Hispanic blacks, almost 60% were unaware. That letter that they received was the first time they found out that they were hepatitis C positive. And likewise, the first time that they found out was very low among Hispanics. So given the problem, the magnitude that we know, and the lack of awareness, CDC proposed these screening recommendations to try to identify, based on what I showed you about the distribution by age, to recommend a one-time testing for adults born between 1945 and 1965 to determine their status. If they're in fact antibody positive, then they were also supposed to, the recommendation is that they undergo a brief alcohol screening, because if nothing else, if people don't get treatment because treatments are expensive, if they're counseled and you can decrease their alcohol use, you can potentially prevent some of the consequences. So if their alcohol screening indicates a problem, then they're supposed to be referred as appropriate so that we can address some of these. And this is a one-time, so of course there are flaws. There could be someone that is negative at this time when they have their one-time screening and then later on becomes infected. Yes, that can happen. But what's exciting about this time, and this prompted some of these screening recommendations, is the amazing progress with hepatitis C therapy. So for a long time, you can see all of this time when we've been dealing either just with interferon or the interferon and ribavirin combinations, when success was low, especially for genotype 1, which is most of the population. Just very recently, there have been the direct-acting antivirals that Dr. Howell will talk to you about that have had much higher success rates. And then just last week, I believe, where Gilead applied to FDA for a very promising drug approval, this is rapidly evolving. And this is a study that looked at if people were treated with the lower success rates from ribavirin, peg interferon, and then added to telaprevir, which is one of the new direct-acting medications, the numbers of potential cases, and the number of deaths that could potentially be averted, the result was that it was in fact cost-effective to do this screening. So the way that CDC has approached this huge problem is using a Department of Health and Human Services blueprint that helps us know in a comprehensive kind of way all of the different activities that need to be done to be able to address the problem. Those include revising policies to expand access to testing, care, treatment services, testing to identify the people that are unaware of their infection, and then appropriate care and treatment. Building capacity to deliver preventive and care services, especially in an integrated kind of way. For example, in STD clinics, in HIV clinics, people who are HIV positive actually have their hepatitis C treatment paid for through Ryan White. Reaching marginalized populations, and to monitor outcomes, which is very difficult. This is about monitoring outcomes and the surveillance challenges with these. So between infection and death, there are multiple events that we could potentially, and you could potentially in your studies at the local level, would be able to monitor. There are sources of data that you can actually use, for example, probably not surveys, but services and providers, claims data, for example, at the local level. Mortality, there are state-specific census databases that you can use to say specifically in your areas how many deaths there have been. And then if you go all the way to the risk, since we've seen that increase among injecting drug users of young people, then there are some, especially HIV-funded risk surveys that you'd be able to look at. And so we don't have the funding for sure that HIV has, but I wanted to mention some of the prevention activities that CDC has. We have funded this past year 10 settings for people who inject drugs and to pay specifically for some of the testing where they recruit, street outreach, drug treatment, and primary care linkages. 16 primary care settings where also they will be funded to conduct testing at community health centers. As I mentioned, STD HIV clinics, medical centers, emergency departments. And there are 2 experiments trying to replicate the Project ECHO, because one of the concerns is that the only people that are currently available to treat and identify, diagnose, follow are specialists, gastroenterologists, hepatologists, and that there aren't enough of those to go around. So this Project ECHO is one that has been successful in New Mexico, where they use telemedicine and call in, and a specialist can see them from a longer distance. So to summarize, the US has a large burden of HCV infection. Most of that burden is prevalent disease. But many people are undiagnosed and unaware of their infection. So we need to get them into testing, and then if they're positive, to link them to care. That needs to improve. And because therapies have evolved to the point where the level of success is much greater, the timing could not be better. To accomplish that, and this is why it's so wonderful that this topic is on your agenda, is that we need collaborations in public health, clinical care providers, laboratories, payers to improve testing, care, and treatment. And that's all I have. So I don't know if you want to do questions or...
Yeah, I'm imagining, and let me just say for the record, Dr. Klevens has a immediate flight that's leaving out soon, but we did want to entertain a few questions if there are any from the audience.
Doctor, over here.
I'm sorry, yes.
With the new medications that have added, has it reduced the time frame for treatment? I'd just like you to expound on that because I'm state representative from Maryland, and I work on a lot of Hep C and Hep B legislation. But in our prison population, I know we have almost 3,000 cases of those with hepatitis C. However, because either they're not incarcerated long enough for the treatment, or the liver is too far gone, or they just refuse the treatment because they have not been properly educated as to how it impacts their lives. We are seeing, of those 3,000, only about 149 of them that are actually in treatment. So I would like to know whether that shrinks the time frame for the treatment.
The treatment guidance, I think, will help in some of that determination. Everyone is not eligible to be treated, but the time, actually, there's been a lot of progress in that area. It's not, in some cases it might be lower, but in some cases it might be higher, and it depends on how they're responding during the initial weeks. There's some measurement of something called very early sustained virologic response. If there is a decline, a rapid decline within 2 weeks of the viremia, then that it might, they might have a shorter course of treatment. Then there's another measure at 4 weeks. People that have rapid declines might have a shorter therapy than people that are not responding. And there are some new futility rules. I'm sure Dr. Howell will cover all of that. Okay. But so it depends.
Well, I'm glad, yeah, because Dr. Howell and I worked on some aspect of that. So I just haven't got the update as to what's happening with the new medication.
Yeah, it's response driven.
I do have one last question. Given the incidence and what appears to be a growing prevalence among Hispanic community, and the fact that the Affordable Care Act and Medicaid expansion does not apply to a segment of that community as far as undocumented. What is the vision that the CDC is having on this issue around treatment, but moreover, even the testing part when they may not have an opportunity to take advantage of whatever screening opportunities are available?
Yeah, I don't even know the answer to that because it's hard enough to try to get the testing within some of these integrated services. Some of these, for example, the STD clinics and those kinds of places are facilities that treat regardless of documentation of who might be a citizen and eligible for insurance reimbursement. So in some of these places they might get tested, but treatment is a whole nother unknown of who is actually going to be able to receive that treatment. Okay. Thank you. Thank you, everyone.
Thank you, Dr. Klevens. They have a formality they want to follow. You want me to? Well, okay. We're going to follow something that's in your agenda. You'll notice that there was to be a special presentation with Dr. Nadine Gracia, who is here, I understand. You want, okay. I'm glad I work in HIV/AIDS. You learn how to monitor and adjust. So, with that being said, Dr. Nadine Gracia is the Deputy Assistant Secretary for Minority Health and the Director of the Office of Minority Health at the United States Department of Health and Human Services. A pediatrician with epidemiology training, Dr. Garcia has served in academic medicine and government. From 2010 to 2011, she was the Chief Medical Officer for the HHS Office of the Assistant Secretary of Health. She provided programmatic and policy leadership and coordination of a portfolio that included child and adolescent health, climate change, disaster preparedness, environmental health, global health, Haiti recovery, and the White House Council on Women and Girls. Most recently, she led the Department of HHS 2012 Environmental Justice Strategy, which addresses the disproportionate exposure of minority and low-income communities and Indian tribes to the environmental hazards and promotes healthy community environments. Her brief presentation today is entitled Moment of Opportunity, the Affordable Care Act, and the Movement for Health Equity. Dr. Garcia.
Good afternoon. Thank you all for the opportunity to come and speak this afternoon, and I apologize as it seems like the 3:45 moment of opportunity was supposed to be where I was, and I was driving in and people said, "Where are you?" And I said, "I thought we were doing this at 4:30, so I truly appreciate having the opportunity to speak with all of you in such really a robust and important forum and Braintrust that is taking place today. It's really a pleasure to be amidst so many champions, so many pioneers and advocates of health equity, and certainly to do so during an important month, an important observance for our nation as National Minority Health Month. It's not only a time, certainly, for us to acknowledge the disparities that continue to impact our country, but also to acknowledge really the remarkable moment of opportunity that we face as a nation towards improving and advancing health equity. You know, the reality is that certainly almost 50 years after the signing of the Civil Rights Act and the creation of Medicare and Medicaid, our nation is continuing to be burdened by these pervasive disparities in health and health care. And as you know, these disparities really persist and exist beyond what we traditionally have thought of as our health care system. That it's certainly many places where people of color live and work, where our children learn and play, places where the social determinants of health are truly stacked against them. But as you also know, these disparities not only burden our communities of color, but certainly our nation as a whole, whether measured in economic terms or measured and considered in the context of the American promise of equality and opportunity. And I'm here today truly because I believe that we have a chance to realize that American promise of opportunity and equality. With 3 years ago, when the President signed the Affordable Care Act into law, opening up an unprecedented window of opportunity in the movement for health equity. Many of you certainly played a role in the passage of that law. I see champions such as Congresswoman Christensen here, who has long been advocating for health equity and the reduction of health disparities. Many of you understand the journey that it took for us to get here. From the doubts and debates about aiming too high and thinking too big, to the naysayers who doubted that it would withstand the challenges that came its way and truly take hold in the way that it was intended to be. And as the implementation of the healthcare law now unfolds, we really can step back and recognize all that it truly represents. It is, in the words of our U.S. Secretary of Health and Human Services, Kathleen Sebelius, not just a law. It's the culmination of decades of work, the kind of historic step forward for equality and opportunity that most of us may only see once or twice in our lifetimes. And we can see that truly it is already making a difference. And that's because the healthcare law really tackles many of the levers that have long been associated with health disparities. Levers that were identified in that Sentinel 1985 report of the Secretary's Task Force on Black and Minority Health that led to the establishment of our office, the Office of Minority Health, to other landmark reports such as the Institute of Medicine's unequal treatment. We understand and we know that lack of insurance poses one of the most significant barriers to care, and perhaps more than any other demographic or economic factor determines the timeliness and quality of that care. Where minorities make up only 1/3 of the U.S. population, they make up more than half of those who are uninsured. We see the impact with relation to cost, the cost of recommended preventive services, the discriminatory practices of insurance companies, where in particular for the nearly 130 million Americans with pre-existing conditions such as diabetes or heart disease would be subject to higher premiums, limitations on the amount of care that would be paid for over their lifetime, or prohibited from accessing health insurance at all, that all of these presented further obstacles. But because of the health care law, we are seeing millions of uninsured and underinsured Americans, including many people of color, now have options for the health care coverage that they never had before, thanks to provisions of the law that are ending discrimination due to pre-existing conditions, conditions that we know disproportionately impact minority populations, or provisions of the law that enable young adults to be able to stay on their parents' health plans until the age of 26. Already more than 3 million young adults have been able to gain access to health coverage because of that provision in the law, many of them who are young adults of color. And thanks to unprecedented investments in preventive care, millions of minorities now have access at no out-of-pocket cost to the important preventive services that they have struggled with far too often in the past to obtain. 71 million Americans with private insurance who are now getting free preventive services. We also know that people of color are among those who are benefiting the most from the healthcare law's investments in primary care, in increasing the number and expanding the services of our national network of community health centers, centers that serve as really our nation's safety net, providing care to the most vulnerable and underserved, where more than half of the patients seen in those centers are racial and ethnic minorities. But we know that we also must strengthen the nation's health and human services workforce. That will help us to improve the care for those who are most in need. And that's the idea behind investments such as the more than $10 million awarded in loan repayments to the National Health Service Corps, an innovative program that is encouraging, for example, more medical students to work in primary care and bringing more primary care doctors to our most underserved communities. Thanks to the health care law and some other historic investments, we've seen a near tripling of the size of the National Health Service Corps since 2008. And when we look at the demographics of those who actually serve in the Corps, we see a compelling trend. For example, we can look at African American physicians in the national physician workforce, who represent just a little over 6% of the physician workforce. But when you look at the statistics in the National Health Service Corps, nearly 18% of the physicians are African American. It shows certainly and reaffirms the commitment of minority physicians in practicing in underserved communities and providing culturally competent care. The law is also taking measures to strengthen our data collection, where we as a department develop new data collection standards to address race, ethnicity, primary language, sex, disability status, confronting the long-standing obstacle of the lack of standardized data collection, not only to help us identify disparities, but really to also target effective interventions to reducing those disparities. And the law also acknowledges the important linkages, not just of the healthcare system, because we understand that certainly our health is not just influenced by what happens in the doctor's office or in an emergency room. We understand certainly the important linkages to be made in public health, prevention, and healthcare, calling for the first time ever a national prevention strategy that is led by our U.S. Surgeon General, Dr. Regina Benjamin, that truly embraces this multi-sectoral approach, addressing health and human services, addressing transportation, education, labor, housing, and urban development, an unprecedented time in which we have all of these partners at the table talking about how we can work to eliminate disparities, advance prevention, and truly become a healthier nation. From opening new doors to coverage to strengthening access to investing in our nation's health workforce, the healthcare law is truly one of the most powerful pieces of legislation that we have in our nation's history to help us reduce health disparities. And so that is why it is one of the strategic priorities of my office, the Office of Minority Health, to ensuring that as we move forward in our vision to help set and shape policy, refine policy, and implement strategic initiatives that we recognize certainly this moment of opportunity that the Affordable Care Act provides. But we certainly recognize that it isn't enough to just initiate a transformation, because too often sweeping change has a way of missing the communities that need it most. And so that's why, under the leadership of our Secretary, Kathleen Sebelius, we also launched the first ever Disparities Action Plan. It was launched 2 years ago this month, and it's really holding all of our agencies accountable for how we will work to reduce disparities through our programs and our policies. To implement this plan, our office plays a leading role in overseeing the implementation, but we are working collaboratively with the directors of the offices of minority health that were established or authorized through the Affordable Care Act. I know that you heard from one of my colleagues this morning, Dr. John Kabul, the director of the FDA Office of Minority Health. Together, we are working to really strategize on how we can effectuate policies and programs, initiatives that will help us to reduce disparities. And since the last year that I spoke to you, all of the directors, all of the offices have appointed permanent directors who are providing critical leadership in the department to ensure that minority health and health disparities are addressed in everything that we do. This includes programs, for example, like the Substance Abuse and Mental Health Services Administration. Under their leadership within the Office of Behavioral Health Equity, they are working with a Minority Fellowship Program, which is working to expand the behavioral health workforce, recognizing that we need such a workforce that is culturally and linguistically appropriate to address the needs of traditionally underserved populations, populations where we know even the words mental health are often still so taboo in our community. We're drawing on new technologies and tools to improve care for those who have too frequently been dismissed as hard to reach. Last year, for example, our office partnered with the Office of the National Coordinator for Health Information Technology to launch the first ever Disparities-focused app challenge, a call to software developers to design a mobile application that women who are at risk or who have already been diagnosed with breast or gynecologic cancers like cervical or uterine cancer, to be able to use this type of mobile application device to send preventive services recommendations, screenings information, connections between their providers, and to do so in a culturally appropriate manner. All of these are ways in which we're turning to new platforms to address health disparities and raise awareness of the opportunity to advance health equity. Each of these initiatives focus on a different area for improvement, a different lever for progress. But what they all have in common is that we cannot solve these disparities alone, that no single individual or organization or sector acting alone can eliminate health disparities, because this is truly just the beginning. Starting this October, the opening of the new health insurance marketplaces will introduce a whole new way for Americans to shop for health coverage. Millions of Americans, including many people of color, who will have new opportunities to gain coverage, in some cases for the first time. But a challenge we face is educating our communities and getting people enrolled and connected to care. And that's why we chose the theme for this year's National Minority Health Month as Advance Health Equity Now, uniting our communities to bring health care coverage to all. As we prepare for October 1st, we must draw on all of our partners, all of our networks, to make sure that we're getting the word out and reaching those who stand to benefit the most. As the implementation of the Affordable Care Act continues, our charge certainly is to press ahead, to keep the momentum going, to ensure that we make the most of this remarkable moment of opportunity. And that sense of urgency has never before been more evident. Health equity being in the spotlight on the national agenda, and with that comes truly an unprecedented time, one that calls for everyone to be at the table. And whether we rise to meet it, whether we can look back 50 years from now and consider this period in history as the moment when everything began to change, it truly depends on all of us working together. So as we look to the road ahead, let me say very simply, we need your help. We need your expertise and your influence in your communities as trusted advocates, trusted members of your communities, and on the front lines of services and care. We need you to continue to sound the horn of achieving health equity so compellingly and so powerfully that there is no room for doubt as to how high the stakes are, not just for minorities, not just for our communities, but for our country as a whole. And if each of us can continue to take that step up and do our part and work together to ensure that all members of our communities have the opportunity to live healthy lives, I truly believe that we can make the most of this opportunity. Thank you very much.
Yes. Thank you, Dr. Garcia. I think we're probably at a closure moment. And so, just as a quick recap, one of the things, if you look at your schedule for tomorrow, if you're anything like me, when I looked at that schedule, I could see that tomorrow was going to be a dynamic day. There are some critical topics that will be covered around the Affordable Care Act, around Ryan White, around Medicaid expansion. And they say that all politics are local. I think what's going to happen when we leave here, as we go into tomorrow's agenda, I think one of the key issues will be for all of us is what do we do when we get home? How do we transfer this information to people who are not as excited about this process as we are? I know that one of the advantages that I have had, and I'm grateful for being part of this process, is that there are some of the brightest minds in this country, even sitting in this room, where we can learn from one another. But when we get home, we have to figure out what we are going to do with the individuals that need these services. I know that health departments, although we have relied on them in the past, they are hurting for resources. They're referring clients even to community-based organizations like ours. We are struggling. Some of us will make it through this transition of affordable care, and some of us will not make it. And so we have challenges that lie before us in our partnerships and how we can get with our business associates and move into conversations with insurance companies and paths that we were on. We have to move in a broader path and expand our understanding of what needs to go on. So I will say in closure that one of the most exciting things that we've seen in the past couple of days is around this peer navigation. There is a RFA that's out even as we speak, where we will have an opportunity to partner with a broader community and figure out how are we going to get this information to the people that really need it. And it's going to call for us doing some traditional and non-traditional things. We may have to go back to our cookbooks and find out that we may have to go out late at night to get to some of these folks that we need to get to. We may have to do it at non-traditional hours, but at the end of the day, if we're holding hands together and we're making a commitment one to another that we'll have to do what we have to do, then we'll make it happen. So I appreciate the opportunity to moderate today, and there's one more speaker.
Thank you for your indulgence, and as you recall, due to some travel modifications, we had to invite Dr. Howell to speak now. So I'd like to bring Dr. Howell up, and this will be our last session for the day, but it's on an area that's a particular interest to me. But again, Dr. Howell is a professor of medicine in the Department of Medicine at the University of Maryland School of Medicine. Dr. Howell has had a long interest in racial disparities, including chronic hepatitis C treatment, and was an investigator in the NIDDK Vera-Hep C study. Dr. Howell's clinical interests include the management of chronic liver diseases, particularly hepatitis B and C. So it's with great pleasure I'd like to introduce Dr. Charles Howell. Thank you.
Well, good evening. Well, thank you, Bill. First, I want to thank the National Minority Equality Forum and the organizers of this meeting for the invitation to participate. I also want to thank you, because the day is getting late and long, and and I know that probably dinner's waiting. So what I'm going to try to do, I have a PowerPoint presentation, and I'm going to try to pursue it and stick to it, but I also will be cognizant and try to make it painless. Okay, let's see here. So anyway, I was asked to talk about treatment of hepatitis C, and actually my expectation was that my talk was going to follow the presentation by Dr. Klevens from the CDC regarding the epidemiology of hepatitis C, because I think it's a perfect introduction and backdrop for the talk that I'm planning to present. And hopefully you will remember a lot of the things she said, because I think right now we're at a very critical time in the evolution of hepatitis C in the U.S. Mortality rates have been increasing. The morbidity in terms of liver cancer has been rising, and it's projected that it's going to get worse over the next couple of decades. And so the issue of treatment looms large because for persons who have infection, actually the only way that we can mitigate or prevent these negative consequences of infection is really by eradicating the virus. And so I start with basically a first slide, which, let's see here. Well, anyway, which basically emphasizes the point, a take-home point is that we can cure hepatitis C with medical therapy. And I think that that's an important concept, because for most of the other blood-borne infections, the chronic infections, HIV and chronic hepatitis B, for the most part, while we have treatment to suppress the virus, we're unable to eradicate or to cure the infection, such that patients, for the most part, have to remain on treatments indefinitely. But for hepatitis C, we can cure this virus with a finite period of treatment that actually is, somewhere between 24 to 48 weeks in the majority of people. And so as I'm talking and presenting data regarding these clinical studies and clinical trials that prove the efficacy of hepatitis C, I'm going to use a concept or a term that's called a sustained virologic response. It's abbreviated SVR. And basically, we've been using this. This has been the endpoint of clinical trials for hepatitis C since 1991, when the first treatment was approved by the Food and Drug Administration. And what it is, the virus is undetected at the end of treatment and remains negative or undetected in the blood for at least 24 weeks after treatment has been completed. And so we know now that if one achieves that SVR, this is tantamount to a cure. Because if you follow patients for many years after that, the virus remains undetected in 99% of persons. And it's associated with improvements in liver injury. So we use liver biopsy, we say histology, liver biopsy. If you look in the biopsy, the liver damage in the biopsy, both the inflammation and the scarring that happens as a result of hepatitis C can be reduced and actually regress in some cases. And then more importantly, when you look at clinical complications of infection, such as development of end-stage liver disease, liver cancer, and deaths relating to hepatitis C, persons who achieve this SVR actually show a decrease in all of those complications. So it's important to acknowledge that. And so as we proceed, where we are right now, it's very important for people who have hepatitis C to be identified and to get into care and treatment if that's needed, not recognizing that not everybody will need therapy. So as we begin to talk about treatment, it's important to note that the hepatitis C virus is very diverse genetically, and actually it's organized into into variants that are called genotypes, and they differ geographically throughout the world. But in the United States, the main genotype is genotype 1, and it's present and accounts for 73% of the infections. The remaining infections are due primarily to genotypes 2 and genotypes 3. Now, these infections, these genotypes, do not influence or predict the outcome of infection, like whether somebody's going to develop cirrhosis or liver cancer or not. But they are the major determinant of response to treatments. They have been in the past and continue to be so. So it's important to note. Now, what I'm going to do in this slide really shows the advances in treatment for hepatitis C in terms of the SVR rates or cure rates. And so as you can see that in 1991, when interferon became the first treatment for hepatitis C, actually it was not very effective at all. Only about 6% of persons would achieve a cure rate from their hepatitis C infection. But with modifications in treatment and the addition of other medications, such as ribavirin, we reached 42% around 1998, and then about 54 to 56% in 2001 and 2002. And those results are shown in the blue slides, in the blue histograms. Over here it's going to be to your right, this 42 to 46% really tells us what the response rate was in patients who had the most common variant, the genotype 1, so 42 to 46%. But those patients who were infected with the genotypes 2 and 3, actually they had 75 to 82% cure rates. And that's been historically the case, that they respond better to therapy. But if you look farther to your right, you see two tall bars here, and they indicate the results that have been achieved in clinical trials of the most recent advance in therapy, the development of hepatitis C protease inhibitors, telaprevir and boceprevir, where the cure rates for genotype 1, the most difficult to treat form of hepatitis C, was 68 to 79%, which is quite impressive. And now we have response rates in patients with genotype 1 with these agents are similar to the response rates in genotypes 2 and 3 treated with just the 2 drugs that preceded them. So it's quite impressive. So I'm going to just talk some about the protease inhibitor treatments that were recently approved by the Food and Drug Administration for genotype 1. I don't know if you can, oh yeah, it's big enough to read. So there are 2 of them. They're actually different drugs, but they actually have a lot in common in that, first of all, they're both oral medications and they're administered 3 times a day. And they must be given in combination with the previous standard of therapy, pegylated interferon and ribavirin based on body weight. You cannot use these protease inhibitors by themselves. If you do, the patients will develop resistance to the infection usually within the first week or so. So you must use it. And so adherence to therapy becomes very important. You need the pegylated interferon and ribavirin to eradicate any of the resistant variants that may emerge relating to the protease inhibitors. These medications were approved. They have similar indications. They're approved for both patients who were not previously treated, the so-called naives, the people who failed prior therapy, and patients with compensated liver disease, including those with cirrhosis. But they must be stable without complications. And then both of these regimens have something that's called a response-guided component, meaning that for patients who have a very rapid response to the treatment, the duration of treatment can be reduced from the typical 48 weeks down to 24 weeks without losing any benefits of the therapy. Again, with actually somewhat higher response rates, around very high response rates, if you can achieve this early response. So a few things just, let's see here. I've kind of introduced most of this information, but it's important to say that these treatments are only approved for patients with genotype 1. So it's not approved for patients with genotypes 2, 3, 4, 5, 6, primarily because these other genotypes are not as sensitive to these agents as the genotype 1. And lastly, they are not approved for certain categories of patients for whom we really do need effective therapy. Patients, the groups in which hepatitis C tends to be more severe or more prevalent, but so far they have not been approved. We should state, though, that these drugs and others that have come after them are being studied in these populations, and we should begin to get some results soon, and hopefully an indication in terms of FDA approval. So regarding the protease inhibitors, this basically kind of schematizes what happens. It's a schematic of the hepatitis C genome and the gene products, basically identifying potential targets, not only the targets for the protease inhibitors, but also for other classes of inhibitors, other targets that have been developed actually and are making their way through clinical trials. But the way the protease inhibitor works is that the virus has a very small genome, And that genome encodes for both structural and non-structural proteins. These greens are the structural and the purples are the non-structural. But when the virus gets into the cell, and its first order of business is to remake itself. So what it does is it takes its genes and starts to make proteins based on the genetic code. But initially, that protein is just one big long protein where all these proteins are just joined together. It's called a polyprotein. So in order for the virus to be able to reproduce itself and to assemble, these proteins have to be cleaved into their component parts so they can do their work and actually be assembled into a complete viral particles. And that's where the protease comes in. The virus encodes a protease, the NS3 protein, that actually cleaves this polyprotein, at least on the right side, into the component parts so they can become active. Most of these are enzymes that are involved in different aspects of virus production. So this protease inhibitor was the first class of direct-acting antivirals that were discovered. But subsequently, there have been other classes of inhibitors that have been identified, the NS5A inhibitors, NS5B inhibitors. Unfortunately, we're not going to have a lot of chance to talk about them. Most of them are basically investigational, although some are getting close to the point where new drug applications will be submitted. I'm just going to go through briefly some of the information regarding this. I'm not sure how critical this is for the audience, but I thought I would do it because there are some slight differences in the way the medications are administered. Boceprevir, which is one of the drugs that I identified, the way the medicine's used depends on whether a person is being treated for the first time or whether they actually have been previously treated and failed therapy. But regardless, this treatment starts with just two drugs, the pegylated interferon and ribavirin, for 4 weeks, after which the boceprevir is added, and the treatment is continued for varying periods depending upon how the person responds on treatment or this whole issue of the prior response to therapy. So anyway, once boceprevir started, we check the virus RNA at week 8, and if it's undetected at week 8 and week 24, we can stop treatment after 28 weeks. If the virus is detected at week 8, then patients are continued on the triple therapy for 36 weeks, and then boceprevir is stopped, and pegylated interferon and ribavirin continued for another 12 weeks. For those people who have failed prior therapy, there's a slightly different duration. It starts the same. Boceprevir is added. If they have this rapid response with undetectable HCV RNA, then all treatment stopped at 36 weeks instead of 28 weeks. If not, it goes triple therapy to 36 with another 12 weeks of treatment. The only difference in this is that in patients who have cirrhosis, it's recommended that because they don't respond as well, that they be retreated for the full 48 weeks. Now, I went through a lot there, but the point is that as you can see, that the regimen is a little complex, and it's one of the shortcomings of this type of therapy. Telaprevir is a little simpler and a little less complex, but nonetheless, you'll note that in this study, for this treatment, patients who've been never treated before, those who had a relapse from prior therapy, that means that the virus was negative at the end of treatment but came back, they're kind of treated similarly. But regardless of whether your response, whether whether you're not previously treated or previously treated, telaprevir is administered for 12 weeks with pegylated interferon and ribavirin, after which telaprevir is stopped. If you have a rapid response, undetected HCV and RNA at week 4 and 12, you'll stop at 24 weeks. If the virus is detected at low levels during that time, then you'll stay on treatment for 48 weeks of total therapy. And for those who were previously treated, either were partial responders, that is, they had a 2-log drop in HCV RNA, but the virus remained positive, or if they fail to have a 2-log drop, they get treated for a total of 48 weeks. And again, patients with cirrhosis, regardless of their response, should probably be treated for 48 weeks. So this is just some of the results. I mean, we'll just go through this quickly. This is the boceprevir study. Now, remember, I indicated that both of these agents, there's something called a response-guided treatment arm where you can shorten the treatment in patients who have a more rapid response. But here, this slide is comparing the two boceprevir regimens, a 48-week and a response-guided treatment, to just the standard of care at that time, which was pegylated interferon and ribavirin. And you can see that regardless of the arm of boceprevir, it was superior in efficacy in terms of SVR compared to the prior standard of care, and was also associated with more durable response in that when treatment was stopped, the boceprevir arms had lower rates of relapse of the virus infection. This slide actually, this study actually, historically, African Americans and other non-white populations have been underrepresented in these phase 3 clinical trials. Kudos to Merck and Shearing at the time for making an effort to enroll adequate numbers of African Americans to be able to have some sense of how the medication, its efficacy and safety in the population. And so we know from previous studies that African Americans, in terms of the previous therapy, this control arm down here, did not respond as well as whites. So, and that was confirmed in this study, where African Americans, 23% had an SVR compared to 40% of whites. But you'll see that compared to, in both of the races, compared to the control, both boceprevir arms had demonstrated superior efficacy. Interestingly, in whites, both response-guided and 48 weeks of the 48 weeks fixed duration had similar efficacies. However, in whites, response-guided therapy was not as successful, such that one of the modifications in the treatment guidelines is that African Americans should probably not be treated with the response-guided arm. Telaprevir, same type of results. Again, in this study, you have a telaprevir triple therapy for 12 weeks or 8 weeks, followed by pegylated interferon and ribavirin to complete either 24 or 48 weeks, compared to the control arm, basically showing that, again, telaprevir, regardless of the arms, were superior to the previous therapy. And the other part about it is that when they looked at the people who had this exceptional early response, it's about 60%. So about 60% of people were eligible for shortened duration of therapy, which is not a small issue when it comes to these treatments. Racial differences, basically similar to boceprevir, we saw similarly lower response rates in the African Americans compared to whites, Caucasians, and Hispanics. So 60 to 62% in blacks, 73 to 79% in whites, 68 to 77% in Hispanic populations. So similar to the prior treatment, we still continue to see this racial difference in treatment outcomes. Now, there are other factors that predict whether a person is going to respond or not, and some of those are shown here. The baseline virus level. There's a gene test that also is associated with the response. And in that case, this is called interleukin 28B, and people who have the CC type variant of the gene have much higher responses than those who have the CT and CTT types. You'd be interested to note that African Americans are more likely to have that CC than the other populations, and that is likely to be a factor in the lower response. Persons who do not have cirrhosis do better. We already talked about race, and then when you look at subtypes of the virus, those who have genotype 1B do better than those with 1A. I'm just going to move forward. The other major predictor of response is the amount of scarring in the liver biopsy, such that, as shown in this slide, patients who have more advanced bridging, fibrosis, and cirrhosis, more advanced scarring, as opposed to those who have less scarring, also have lower response rates. And that's true also for both of these medications, without going into a lot of detail. When you look at patients who've been previously treated and failed therapy, you see a kind of different picture. That is, the likelihood of responding to these newer class of drugs depends on the pattern of response during the prior treatment. So patients who previously relapsed, that means they were treated with pegylated interferon and ribavirin. The virus was negative, but when they stopped treatment, it came back. They have very high response rates, actually 83%, as high or higher than patients who were never treated before. On the other hand, as you go to your right, you're looking at groups of patients who are more and more resistant to interferon. So these partial responders and these null responders, they have a decremental, a further decrease, gradual decrease in the likelihood of an SVR, with 60% for the prior partial responders and 29% for the null responders. And that's also true for boceprevir. So these medicines, despite their significant impact in terms of increase in response rates, they have several limitations. And one of those is treatment-related side effects. And so we know that the pegylated interferon and ribavirin therapy without the protease inhibitors have a lot of side effects. And those side effects will continue in patients undergoing treatment with the protease inhibitors. But what we also observe is that there are certain side effects that are more common in patients treated with the protease inhibitors triple combination compared to the dual therapy. And those include a much higher rate of anemia and abnormal or foul taste in the mouth. These other side effects were not any higher than seen in pegylated interferon and ribavirin alone, and are probably just reflecting the impact and adverse effects to those two agents. For telaprevir, you'll see a similar pattern of adverse events with a few exceptions. First, anemia, again, as in boceprevir, was much more common, 36% in those receiving telaprevir compared to those who were in the control arm, where it was 17%. But you'll see that there are a number of other side effects that are fairly unique to telaprevir compared to boceprevir. Those include skin rash, itching of the skin, nausea, anemia. Anemia is similar to both, and flares and hemorrhoidal symptoms. That is, hemorrhoidal flares, anal rectal discomfort, and itching are much more common in patients treated with telaprevir. Recently, the FDA, concerning this rash, actually during the clinical trials, about 6% of people had to stop therapy because of the rash. But recently, the FDA issued a black box warning regarding the telaprevir-associated rash because there were 2 cases of severe rash, one of which resulted and was associated with death in a Japanese patient. And so there's a black box warning concerning how to manage, notifying providers about this, but also providing more guidelines about how to manage the more severe rash. It's important to note that for the most part, patients who develop rash have tended to have, at least in the trials and in the subsequently in the U.S., have tended to have milder rashes. There are some other problems. These medications have a lot of drug-drug interactions. So they're both metabolized by a drug metabolizing enzyme in the liver called cytochrome P453A4. It's an inhibitor. It's partially metabolized, but they also inhibit this cytochrome. And so there are many drugs, many common medications are also metabolized by the same enzyme system, such that if you administer them with these agents, you may have either an increase in the levels of the drug, increased exposure, and in some cases, where they are stimulating the drug, they may also lead to decreased exposure. And so there are a large number of medications that cannot be taken with these, and an even larger number where there are significant interactions, and one has to really be cognizant of that and make sure a very thorough medical history is done. Also, as a result of this, patients have to keep the providers informed if they start any new medications because of that potential. The last kind of major issue that has emerged with these new therapies is that of resistance to the protease inhibitor. And so what happens, the way it goes is that because the virus mutates so rapidly, everyone, well, I shouldn't say that, a significant percentage of patients will have some of these resistant variants before treatment. And so those are interspersed among the group of sensitive variants. So you start the telaprevir, if you use monotherapy, use it as single therapy, the sensitive viruses will be suppressed, but the resistant ones will persist, and over time will actually expand and to fill in that space that was normally filled by the sensitive population. So as a result, you can't use the medication as single therapy. And also, as a result, it's also important that persons are very highly adherent to the other two medications. These variants that have been noted, they're quite variable, but they also include some viruses that are cross-resistant to the protease inhibitors as a class, so it creates some major issues. There are many other limitations. I'm not going to go into it, but would end by stating that future therapies for hepatitis C are already in the works, and it's become clear based on clinical trials over the last 2 years or so that therapy is actually moving away from pegylated interferon therapy, probably in the majority of patients within a year and a half to 2 years or so. And that's because, again, these other classes of inhibitors have been developed, and actually many of them are actually in advanced phases of clinical trials. And I think we're anticipating some new drug applications actually within the next 12 months or so. They include actually protease inhibitors that can be administered once a day, and they include these other classes of medications, of inhibitors, of which I won't go into a lot of detail, but simply to say that they actually have features in terms of their potency, their resistance, their susceptibility to resistance, and other features that allow them to be combined with other oral medications to achieve very high response rates. And without getting into the detail, it's important to note that even in studies where they're combined with pegylated interferon and ribavirin, or when they're used with interferon-free regimens, we're seeing results in phase 2 studies showing response rates of 90 to 100% in many of these studies, with with treatment as short as 12 weeks. So got a little ahead of myself, and this is the future. So these medications are being studied in different types of combinations, and we're looking forward actually to the completion of these, and the approval for use in the general population. If there's one thing I would say that's somewhat disturbing as it relates to the direct-acting trials is that the problem that we've experienced with hepatitis C therapies over the years has been basically poor enrollment of minority populations, African Americans and other non-whites. And so far, in these direct-acting antiviral trials, after the protease inhibitors, this has continued to be a problem. So it's a problem that deserves the attention of the sponsors of these studies, the investigators, as well as the Food and Drug Administration. So we need to, we have participated in some studies, and we find that the African American patients are willing to participate in studies, but they have to be approached, and they have to be approached with sensitivity. So we desperately need these because we need to know how these medications are going to behave in the population. We need better therapies. We need evidence-based management. And ultimately, the data is necessary to provide the highest quality of care for our patients. With that, I'll stop and entertain a few questions.
I do have a question.
Oh, okay.
Yeah, In ophthalmology, we have different trials for the treatment of retinal vein occlusion, macular edema, diabetic retinopathy, etc. In all these trials, there's also a limited representation of Hispanics and African Americans. And I think that probably what happens, because I've seen this in my patients, is that some of the persons in these minority groups cannot travel to the places where the trials are taking place, like sending them, for instance, in my case, to university. They cannot travel from South Bay to La Jolla, etc. And, you know, the university probably does not do the effort to reach them in their location.
Yeah. Well, I think that there are many probably reasons why the enrollments are lower. And of course, you mentioned some of the important barriers, but I think that my observation is that for most of these studies, the centers that are selected are the same, kind of repeatedly, and so you end up with the same population. I think there needs to be more diversity among the investigator staff. And it needs to, interestingly, the Shearing made a special effort to enroll African Americans. If you prioritize it and reward it, then it will happen. But if you don't, then, if you continue to, to do things the same way, it's unlikely that we're going to get any different results. But I think it's important.
Thank you.
My name is Loretta Jones, and I'm with Healthy African American Families in Los Angeles. And one of the things that I'm over here sitting down.
Oh, I see. You're sitting down.
I'm challenged some days. Okay. And I work in communities. And one of the things that I find is we don't get out to the communities where the people are that can help us recruit participants and keep them in clinical trials. We tend to have them at the universities or in the hospitals, and we don't go to the communities, and we don't talk to the people in the community that know the population really well and can work with the population. So wouldn't it be beneficial to actually have clinical trials and you have your partnerships with community-based agencies that actually see these people on a regular basis and can help, 1, recruit, 2, retain, and 3, get the information back to communities so that communities can participate better?
I think you have some very excellent suggestions, and I think those type of partnerships it's just one of the strategies that would certainly help to address the problem that we have. So I would agree with that. I think we have to try. Just has to be multifaceted strategies to do it. But you do raise an important point. Okay, thank you.